Okay. Good morning, everyone. My name is Omolara Abiola. I head Alpha for Union Bank, and as you know, Union Bank is the bank that supports women. Our goal and our aim is to enable women, regardless of their life stage. So, whatever or wherever you are, Alpha is right there to support you, to help you, to help you grow through your health, through your savings. If you have a need for a loan, Alpha is right there for you. If you require coaching and mentorship, discounts on your purchases, Alpha is right there for you. But today we are delving into talking about our health as women. Some of the things that we typically overlook, that we do not tend to tend to. As you know, in every home, the woman takes care of herself last. She typically will take care of her husband and her children and her mother and every other person but herself. But we have gotten to the point where we have to actually we need to deliberately change the narrative. That's why today we will be talking all about breast and cervical cancer. Now, like, why are you guys why are you talking about the dire of the direst of things? But we have to bring it forward. We have to make it a norm to talk about these possibilities, or these possible intricacies that might happen. But what can we do about it? People will say early detection is key. It actually helps to know what your status is, what's going on in your body and all. And to that end, I will like to introduce our two panelists today for our roundtable. Dr. Oluwaseun from Clinix Lab Investigative Laboratories. Clinix is one of Alpha's partners. They've been supporting us with discounts on healthcare for women, and they've been supporting us with about 10% discounts on investigative laboratory tests. Welcome, Dr. Oluwaseun. And we have Dr. Emmanuella Nwachukwu. She is the resident oncologist at National Hospital in Abuja, and she's here to help us break everything we need to know about breast and cervical cancer down to us. So, Dr. Oluwaseun, I want to give you the floor for introductions, then I'll pick it up, then Dr. Emmanuella can pick that up, then I'll wrap up introductions and we can go ahead.
Good morning, everybody. Thank you, Omolara, for having me. We're going to be talking about something that's really important to all females in the world. And we're going to be talking this morning about breast cancer, and we'll talk briefly also about cervical cancer. So let's start with breast cancer. Breast cancer is cancer that arises due to uncontrolled divisions of the cells within the breast. So breast cancer, let me start early by demystifying the myth that it doesn't occur in men, because about 1% of cancer cases also occur in men. So breast cancer is something that is the commonest cancer diagnosed in women worldwide. It's followed by cervical cancer. In Nigeria also, breast cancer initially in the 1970s used to be about 11 out of 100,000. But now it's risen to about 46 cases out of 100,000 women. So breast cancer is something that is getting common. And it's also been established by World Health Organization that 1 in 8 women stand a chance of having breast cancer in their lifetime. What are the things to know? Like Omolara rightly said, early detection is key. Early detection saves life. And that's the essence of this awareness that we are having. You need to know what to look out for. You need to know how to protect yourself from having breast cancer. Like in all cancer cases, breast cancer has no exact cause, but there are risk factors that could make someone have breast cancer. we can have the risk factors being shared on the screen. So there are modifiable causes of breast cancer, and we also have non-modifiable causes of breast cancers. So for the can I go ahead?
I was just thinking to get Dr. Emmanuella to introduce herself, then we'll just do the housekeeping, then you can you'll have the floor to break it down and all. I'm so sorry.
No problem. Over to you, Dr. Emmanuella, it's fine.
Okay, good morning, everyone. Thank you, Lara, for this invitation, and thank you to the Alpha Women. I am very happy to be here this morning. I hope everyone can hear me.
Yes.
Okay.
Yes, so I can hear you loud and clear.
Okay, so my name is Dr. Emmanuella Nwachukwu, but most people call me Dr. Ella. I am a consultant clinical oncologist, which means I manage cancer patients using both chemotherapy and radiotherapy. And today we're going to be talking about breast cancer, all you need to know. But I think if we have women gathered, it's not right to talk about the breast without talking about the cervix. So we're also going to be throwing in a little bit of what you need to know about the cervical cancer too. So I'm happy to be here once again, and I look forward to a very engaging discussion. Thank you.
Thank you so much, Dr. Emmanuella. Thank you, Dr. Shewan. I apologize for interjecting. I just wanted us to at least have proper context, because I know that it could easily be deemed as one of those things that we want people pay lip service to. But we want to make it real, right? We don't want to just have a webinar for what it's worth. We want to make it as real as possible to our women, so that they know that, okay, look, I don't want to make light of it to say it's not a big deal. It is a big deal, but there is help available for you. And I'll use myself as the guinea pig here. So in 2014 I had my second child, and I breastfed him and weaned him after a year. And I just noticed that I will still have some sort of discharge. But in 2019, it became really, it was a lot. And I was just really worried about what was going on there. So I spoke to my older sister, who's a general practitioner in the UK. And she was like, Lara, you need to get yourself checked out. Just go and get yourself checked. It doesn't matter. It's not a big deal. That just go and get yourself checked out. We'll pick it up from there and all. And I started getting conflicting advice. I got advice that, oh, you should go and do is a mammogram you must do. If you do a breast scan, they might not see some cells. And at that time, I was still in my 30s. So there was no need for a mammogram, really. So I went to clinics, ironically, and I got myself checked, and it was just one of the cases of a weeping mom, being a mom that still secretes from her breast ducts did not particularly completely close up. But the reality of most women is, once they say go and do a breast scan, you've killed yourself. You've been the judge, Georgina and jury. You've killed yourself. You've crucified yourself. You have told yourself, "Oh my God, I am dying. Something is going on here." And some people actually even just freeze out. I did freeze up at some point, because I was just like, I'm not going to do this. What if it is worse? What if it is much more a big deal than I am going through? What if you don't go and look for something? Some people say if you don't go and look for it, you won't find it. So why am I the one going to look for Wala by myself and all of those type of things? But what I realized after that whole episode is I am better for it. I know what's going on with my body. And one thing that I know, and I'm sure Dr. Shewa and Dr. Emmanuella will corroborate with, is your body talks to you. your body is going to tell you when it's not okay, when something is going on. It might be the slightest of symptoms, but as long as you are very observant with what is going on with your body, you will know something. It's like when a person wants to have malaria, right? It starts off with either tiredness or a headache. So your body is already telling you that, look, I'm getting tired. Something is going on. You need to check me out. You need to help me and all of that. So I decided to use my own example so we know that this is a safe place for all of us to talk to one another. This is a safe place for us to break it down as practical as possible. And that is what Dr. Seun and Dr. Emmanuella or Dr. Ella will do for us today. They will make it as simplistic as possible. They will help us to take away from all the nuances that we typically hear and know about, and what you should do if there is a case of cancer. What are your options? If there isn't a case of cancer, how frequently should you check yourself out? But that being said, I'm going to hand it over to Dr. Seun and then Dr. Emmanuella, who will take it off from there. But please, if you have any questions, any comments, just use the chat box, type in your question there, and we'll have a question and answer session where we will dissect the questions, talk about what possible answers there are. The doctors will also provide their contact details and also that of the hospitals they work for on the chat, so that you can pick it up from there. And if you require their services. So Dr. Seun, over to you. Enough of me. Over to you now. Thank you.
Thank you very much, Omolara, and the rest of the alpher crew. Briefly, I'll just mention where I work. I work with Clinix HealthCare. It's an international diagnostic center where we offer a wide range of services. And like Lara advised, that my contact will be up at the end of the meeting, so that if you have further questions, or you're not even sure whether to be a mammogram or a pap smear, or what to do, where to go, I'll be able to answer all your questions. So thank you. Let's go back to what we were initially speaking on, which is breast cancer, what to look out for, and to know the risk factors concerning that could make one susceptible to having breast cancer. Already, there are modifiable risk factors and there are non-modifiable risk factors. I think I should start with the non-modifiable ones. Non-modifiable ones are things that we can do nothing about. Like I mentioned at the beginning of this presentation, cancer of the breast is commoner in women than in men. Men account for just 1% of cases. So being a woman on its own is a risk factor for breast cancer. It's a non-modifiable one. And another factor is increasing age. The older one gets, the more at risk you are to having breast cancer. Then another thing is inherited mutated genes. Mutated genes like the defective BRCA1 or BRCA2 gene. If a woman carries those genes, the person is susceptible to having breast cancer later in life. Let me use an example of, I don't know whether many of us watching movies, Angelina Jolie. She had a double mastectomy a few years ago because she carries the gene. She did not want to, and she already had family history of breast cancer, so she didn't want to put herself through that. She had a mastectomy. Now, you don't have to do something as radical as that, but you need to know where you stand as a woman. Another factor is having dense breast tissue. Now, the breast is made up of connective tissue, fat cells, and the milk ducts. So if the breast is more of dense tissue than fat tissue, though you have no control over that as such, it could also it could lead to having breast cancer later on in life. All right, so exposure we talk about things like family history of cancer, family history of breast cancer, family history of ovarian cancer, or even cervical cancer. All the family history could predispose later in life to having breast cancer. Those are the non-modifiable ones. Now, going to the modifiable risk factors, those are things that you have control over. Those are things that once you know that this is a risk factor, you are able to make better decisions so that one does not progress into having breast cancer. Number one is sedentary lifestyle. If you let me use the word couch potato. Being a couch potato could predispose to having breast cancer later in life. Being obese, being overweight could also predispose to that. Alcohol, excessive alcohol intake could predispose to breast cancer in life. Smoking is also another dangerous lifestyle habit that could predispose to breast cancer. We have things like not breastfeeding. You'll be surprised that there are actually women that choose not to breastfeed their children, not because of health purpose, but sometimes they'll say for cosmetics reason and some other funny ones. So not breastfeeding your child for a long, at least cumulative about a year, not breastfeeding your child could also predispose to having breast cancer later in life. Last one I would mention is hormonal therapy, whether with birth control pills for a prolonged period of time, especially when one is above 35, or even hormone replacements after a woman has achieved menopause. So all that could predispose to having breast cancer. Those are the risk factors. So we'll just quickly take the topics shortly so that we'll give out time for questions and we'll be able to really deal with them in depth. So the next thing I would like to talk about is the signs and the symptoms of breast cancer. If you see it, do you know it is? Now, it's very important for you to know. Being in clinics healthcare has really opened my eyes to so many things. Most of the women I've attended to in clinics with breast lump actually do not have cancer. What they had was fibroadenoma. But because they just had a breast lump, the first thing was initial tears and, thinking that life has ended, even when there's no concrete diagnosis that is what is going on. All right, so the things to look out for, they vary. One, the commonest symptom is lump. Now, the lump is usually painless, though in some cases you could have a painful lump that is due to a cancer. But the commonest symptom any woman would experience is a lump. The lump could be there, then skin changes over the breast. The skin could look like an orange peel. It's called peel d'orange appearance. The skin could look like that of an orange. If you pick an orange and you look at it, the way the dots, and the background is a bit swollen, yeah, something like that can be seen. That is another symptom of breast cancer. In advanced stages, you could have weight loss, wasting, and all. You could also have nipple inversion. Ideally, the nipple should protrude outwards, but in cases of breast cancer, it can retract inside. So when it retracts inside, that something dangerous is going on, you need to investigate. When you see any of the signs, the first thing is not to, how do I put it down? It's not to be afraid. The first thing is to investigate further. What is causing the things I'm changing? Like Lara said, your body talks to you. What am I saying? What is my body trying to say to me? There could also be nipple discharge. Most times it's bloody. In few cases, it could be greenish. There could be, greenish or bloody nipple discharge. You could also have redness over the surface of the breast. So once you see any of those things, you investigate further. And the kind of investigation you would do, I'll talk about it towards the end of the session. It would depend on your age, whether you need a mammogram, whether you need a breast scan, it all depends on your age. So let's talk about how to prevent breast cancer. You already know the risk factors. Prevention can only work for the the modifiable ones. Non-modifiable risk factors, there's nothing you can do about that. Aging, womanhood, and all that. So when one is young, like we are, what do you do to protect yourself? Healthy eating is crucial. You need to eat healthy. You need to take good care of your body, avoid junks. You need to watch your weight, exercise regularly. Once your weight, what I notice is after childbirth, women tend to hard weight. It just somehow, it goes pari passu. But it's for you as a woman to watch your weight. It's for you to do the needful, exercise regularly, eat healthy, avoid smoking, avoid drinking excessive intake of alcohol if possible, because it's really not beneficial to you. It's possible, even stop it altogether. Avoid those things. Avoid radiation. I am not sure if I remember to mention that radiation, exposure to radiation. Yesterday, there was a woman in my office that just had a chest x-ray and she wanted to have another chest x-ray. She just had it less than 2 months ago to have another x-ray. You don't just expose yourself to radiation like that unless the benefits outweighs the disadvantages. All right, so we talked about healthy eating. We talked about, now for post-menopausal symptoms, eat flushes. I know some of us are on this platform have crossed the 50th stairs, eat flushes and all that. there are ways to manage it. You don't have to go for hormonal therapy, but unless it is absolutely necessary. But it's important. Part of the ways you can prevent cancer, breast cancer, is to avoid that. Now, early detection is what saves life. I want us to take that from here. Early detection is what saves life. So how do you detect breast cancer early? There are like 5 different modalities to check for breast cancer. You do the self-breast examination, which we're still going to talk about. While I'm talking about the self-breast examination, Omolara, I would like the slides to be displayed for the self-breast examination.
Okay, yes, we will. And ladies, please, in your homes, feel free to, Dr. Seun, we want to make it as practical as possible so that you know how to do it by yourself, so that you know how to do it properly.
Yes,
all right. So
while the slide will be displayed,
please pull it up.
Okay, while I'm waiting for that to be up, you can also do self-breast examination. You also have clinical breast examination. You have the mammogram, you have the breast ultrasound, and you also have the MRI of the breast. Okay, so self-breast examination will be discussed as soon as the slide is up. Clinical breast examination is simply the breast examination you do in the doctor's office. That's what a skilled professional will do for you. But it's important to know that both the first and the second is actually subjective. That means it's dependent on the skillfulness of the person checking. But it's still important to check regularly, because if you check last month and you're checking this month and you now notice a lump, that means that the lump is possibly less than a month old and you are picking it in the early stage. But if you don't check the breast regularly, if you don't do the self-breast examination regularly, there's a possibility of not even detecting it until maybe a long time or when it's really, really big. All right, so now let's talk about the breast ultrasound before I go to mammogram. Many of us are women and we've had children before. So the way you do pregnancy test and you do scan of the breast, of the womb, to check the baby, that is what we do for the breast also when you come to clinics for your breast ultrasound. A professional would, a doctor would check the breast, and as you're checking it, the slide is already projected on the screen beside you. And also not just the breast, they would also check the armpits as well because of lymph nodes. The lymph nodes that drain the breast, they go to the armpits. So all that area will be checked thoroughly by using the probe of the ultrasound machine. Breast ultrasound is advised for women 40 years, below 40 years. Women less than 40 years, what is advised for them is breast ultrasound. That is because at that age, the breast is more of connective tissue. The breast is dense than fatty tissue. So if you do mammogram less than 40, the possibility of because of the density of the breast, small lesions could be obscured. So for women less than 40, you don't advise them to do mammogram. You do your breast ultrasound. But for women 40 and above, what you do is a mammogram that uses a low dose radiation, because at that age, it is expected that the breast will be more of fatty tissue than dense connective tissue. Dense simply means something like heavy than dense connective tissue. So at what age can you start screening? The age you will start screening for breast cancer depends on your family history and also on your age. People with family history of breast cancers or any other cancer need to start screening from as early as their 30s. Do your breast ultrasound once in 3 years. Once the person is 40 and above, you do a mammogram, maybe once in 3 years too, unless a suspicious lesion is seen. Sometimes they may see something and tell you to do a repeat in 6 months. So all that will depend on what the initial findings is. But if the findings are normal the previous year, once in 3 years is fine until the woman gets to like 74 years old. After 74, there's really no need to do the regular mammogram. But in some cases, let me just touch this before we go to the self-breast examination. In some cases, you could do a mammogram and they will tell you that you need a complementary scan. A few women, it's been noticed that in some cases, women have very dense tissue, even after childbirth and even eating 50s and all. Those kind of cases, you still advise them to do breast ultrasound if the mammogram is not good enough. It's not because there's something wrong with you, it's just because that's the way the body is. All right, so can we have the slide for the self-breast examination now?
Sorry, Dr. Seun, I think Ayomide is having some network issues. She will join us right. So probably we should go to Dr. Emmanuella for a bit. Then once she's back up, we'll all do the self-breast examination together. Thank you very much.
Thank you. That's right.
Dr. Emmanuella, over to you.
Okay. Thank you very much once again. Shehu, you have made my job a whole lot easier.
We can't hear you very well. You need to amplify it a bit.
Can you hear me?
Yes, much better now.
Much better. Okay. So I said thank you very much, Dr. Oluwaseun. You have made the job a whole lot easier for me. So, but one step backwards about the screening. So you also mentioned MRIs, but you didn't state which people, could use the breast MRIs. I think it's something that if we go back and we want to tell people, like you said, if you have a family history of breast cancer and you need to start earlier. So for instance, a woman who is in her 30s who still has the dense breast and cannot do the mammogram should screen with an MRI. So, but with the MRIs, you have to have a breast coil. So it's not every centers that have MRIs that you're able to do the breast MRI. So you need to find out to make sure that it's one of the centers. And it's really good. It helps a lot of my younger patients. It helps us to know the location and the size and everything before we start off treatment. So I don't know, I can see Ayomide is back on. I don't know if we want to do the breast examination before we go into the treatment.
Probably we should, right, Dr. Emmanuella? Ayomide, can you please share your screen, Ayomide? Thank you.
All right, I'm doing that now.
Please move on. The third slide.
Yes, the self-breast examination slide. Okay, yes, thank you very much. Okay, so for self-breast examination, it's important to know when to do this. You don't do it close to your period, and you don't do it few days after your period. You wait preferably 5 days or a week after having your period before you do the self-breast examination. And it's advisable that you also do it after bathing, because when you do it after bathing, there's less friction between the tips of your finger and your skin. So your hand is able to glide easily over the breast surface. All right, so after bathing, a week after your period, you stand in front of the mirror. I hope you have, okay, just as if you have a mirror where you could just demonstrate, and while you listen, stand in front of the mirror. The first thing to do when you're in front of the mirror is to look at the sizes. Definitely one will still be a bit bigger than the other, but it won't be a significant, it won't be like a major thing that's like double the size of the other one or anything like that. So the first thing is stand in front of the mirror with your hands by your side, look at the appearance. So you look before you touch, you look at the appearance, any changes in the skin, any changes in the nipple, in the way the nipple is positioned, you do all that and you just look. Can you see any visible pump, any visible lump on the skin? And then the next thing after looking is to put your hands at the back of your head. When you put your hand, you tense the pectoralis major muscles, yes, and then you look at it again. Look at it. Also advisable to look at the side view. Don't just look at it from the front. Look at it from the side and see whether there's any changes also. Then it's important to note that if you want to check for the left breast, you put the right hand at the back of your head and you now use this. Okay, sorry, it's this way around. You use the contralateral hand. If you're checking the left breast, please, can you see me? If you're checking the left breast, use the right hand to check. and then you go around in either clockwise or anti-clockwise direction. So you can see that it's displaced in the image that we can see. You put your left hand at the back of your head to check the left breast. This will make the muscles beneath the breast to be taut, and then you now go in a clockwise direction or you anti-clockwise. All right, so if you want to check for the other side, you do the same thing. That same side you're checking, put the hand at the back of your head. Then if you're checking for the right breast, use the left hand, to go in a circular manner also and to check. It's also important while you're doing your clockwise motion, once you have gone round the breast, and then you don't move very fast. You move like something like this. Let the pulp of your finger cover as much surface as possible. It's not as if you move from here and you jump to here. No, you move slowly in a circular manner. All right, and you also check the armpit also. While you're touching, while you're palpating the breast, you put your hand to the armpit to check for what you're checking in the armpit is any swelling, any ball-like swelling. Is it painful? Is it just there? All right, so and after doing the clockwise, you do the up and down. You just move up and down, circles and wedges, just go around basically. Then the last thing you would want to do before you lie down is to squeeze the nipple. Now, you squeeze the nipple in two directions, from up down and from left to right. When you are squeezing the nipple, you are checking for any discharge, any nipple discharge. If there is, you know that for a breastfeeding mother, there's definitely going to be. So, but if you're not breastfeeding, check any discharge. Is it bloody? Is it clear? Is it greenish? What color is it? Or there's no discharge at all. So you check from up down, and then you also check from left to right. You do that for both breasts. It's very important. Then you can lie down and also lie down on the bed on a flat surface and also check again. So basically that's how to do the self-breast examination. It's advisable you do it 5 days or a week after your period. That's because towards the period, you know, there's so many hormonal changes that occur at the beginning when your period is closed. The breast is tender, you know, the size could be visibly bigger than it usually is. So that's not a good time to check for it. So you check for it after the monthly period, and it's advisable you just do it once a month. Next month, you could also mark it on your calendar. You know, for those of us that have calendars in our rooms, you could just mark the date, you know, on your calendar. Okay, yes, I've done it. That way you'll be able to give yourself a subtle reminder. Or thank God for phones, smartphones. That's how to track your period and so many things. So you use your smartphones. There's so many apps on the phone that you could use to follow up on health, fitness, and all. So you could also tick that on your phone app that, okay, yes, it's done for this month. So that's, and it's important for us on this platform. Thank you, Alpha team, for having this awareness. It's important for us to teach your family members, teach your friends, teach your mothers, teach them what to do, teach them how to check and what to check for. So basically, you're checking for lumps, you're checking for skin changes, you're checking for nipple retraction, you're checking for any lump, not just on the breast tissue, but in the axilla. And please, it's important to know that if a lump is felt, it does not mean there's a cancer. It just means that you should investigate further. That's why Clinix HealthCare is here for you. You just investigate further to know what is going on. So I think we're good with self-breast examination. If you have further questions on this, you could just put it in the chat box. So when we are taking our question section, we'll be able to answer it. So basically, when you get to your doctor's office, they will still do something similar to this, being a doctor more experienced and all. But what we are really emphasizing on self-breast examination regularly, then do your yearly screenings, or once in 2 or 3 years screening. Thank you very much.
Thank you, Dr. Oluwaseun. Thank you so much. I mean, you can take down the slide. So what I learned is, first of all, look at your, I'll call them, most of us are women here. You look at your girls, which one is bigger than, if there's one visibly bigger than the other, put your hand behind your head, look at her, look at the side, look at the side, just to be sure that you are good. Then you start to feel. And all of this has to be done about 5 days after your monthlies, so that you are not, your hormones, everybody's normal. And you feel, and you also press the nipple top, down, and side by side, right? Yes, thank you. So over to you, Dr. Emmanuella.
Okay.
Thank you, Dr. Seun.
Okay, so today I'm going to be talking about, now you have investigated, you've seen a lump, and the doctor gives you the news that we don't want and we don't like, for you to know what next to do about it, because that's why we're talking about everything you need to know about breast cancer. Something else about the self-breast examination. So for somebody who has stopped seeing their menses, they're like, okay, so when am I going to do my own self-breast examination? You can just pick any date on the calendar, like the first day of every month. Take it to yourself and say, on the first of the month, since I have stopped seeing my menses, I will be doing my self-breast examination at that time. So to talk about the treatment options. Now, if you happen to notice a lump, like Dr. Oluwaseun said, majority of them will not be cancerous. But if that small 20% that end up being cancerous, you need to know what to do so that now that you have detected it early, you can be treated and the chances of you surviving it is a whole lot higher. So the first thing that you would do, apart from the signs and symptoms, the signs and symptoms she gave are signs and symptoms in the breast. Now, the problem about breast cancer is the fact that it has this ability to, one, invade locally to the places around where it is located. It also has one ability that differentiates it from a benign or one that is not a cancer, is the fact that it has the ability to spread. Now, if it spreads, you can have patients come in with back pain as the first symptom because, one, they were not checking, so they did not notice that there was something that was there in the breast that has gone into the armpit and has now gone into the backbone. So they just end up with pain and they come to the hospital. They are seeing the orthopedic surgeons, they're going on and on, I have backache, and nobody bothers to check her breasts. I have seen it happen several times. And at the end of the day, one brave doctor just says, madam, do you have any other complaint? There's this thing that's been in my breast for like 4 years. And that's when you find out that it's the breast cancer that has gone into the bone that is causing the backache. So like Omolara said, and Dr. Oluwaseun said, listen to your body. It does really speak. It tells you something is wrong, so that we will be finding out that, okay, if God forbid, we all don't want it, but even if we're going to find it, let us find it out early. 80% of my patients, when they come to me with this spread. We have to do something to change this narrative. This is the reason why the survival gap between Nigeria and Sub-Saharan Africa and the US is so wide, because they have screening programs available that people routinely go for these screening programs. So they find lumps at a very, very early stage. I don't see these cases as much as I would love to. In fact, I would say under 5% of my patients come with that early stage. So 80% of them come when the armpits are involved, bones, the liver, the lung, the brain. Sometimes I find them at all the organs. They have spread to all these regions at presentation. So this kind of awareness program is something that we have to push for, so that people know that it's not a bad thing, but if you catch it early, then you've done yourself, real good. So what kind of treatment options do we have? The first thing is, after the biopsy that is done to confirm that, yes, this is the cancer, there are further specialized testing that's available to know what type of breast cancer. Right now, breast cancer is not managed as one entity. You have different subtypes of breast cancer. So if you do the testing and they find out that, oh, this is the type that is there, then you narrow your treatment based on that type. So coming and just saying, oh, they say the patient has breast cancer, it no longer works in the 21st century. So we have to do further testing to better manage this particular patient. So with this, we say it is individualized care. Now we have surgery as one of the treatment modalities. If a patient comes with a 2 cm, which is a very tiny breast lump, we have the options of going in and doing surgery, which will just be what we call a lumpectomy, which is just removal of the lump and the region of normal tissue all around the lump. You don't need to remove the breast, because that's one of the greatest fears that make people run away. Some of them, they find it early, they go to the hospital, the doctor they see tells them, oh, you need surgery to take out the whole breast. You will never see them again until they come in stage 4. So, but if you know that it is possible for you to do this breast conserving surgery, so that it's just the region around there, and then the ones in the armpit that will be removed, your breast will still look equal. Something else about they'll say, I know even if they remove small, it won't be equal. There are some people that generally, like you said, one breast is bigger than the other. So it might be in your a lot bigger breast, such that when that region is removed, you have it equal. There are also some women whose children suck only one breast. So you always need to know what is normal for you. So I've seen people who have day and night. That's how the breasts look like. One is so small and the other one is so big because all her 4 or 5 children only suckled one breast. So that kind of person, you need to know, okay, this is my norm because I didn't really breastfeed from the other one. And you need to know, okay, when there's a change. So going back to the treatment. Now, if the surgeon gives you the option that you need to remove the whole breast, we are also moving towards the region that there's plastic surgery for you to be able to do to reconstruct the breast. So reconstruction is also available if you have to remove the breast completely, but this would only happen if you're coming in a more advanced stage. So I will not push for that. I will tell people, if you come early, screen, card, take it from me, mastectomy is only if you choose that you want to do that mastectomy. The second treatment modality is the use of chemotherapy. There are a lot of myths that have been said about chemotherapy, how dangerous, if you take chemotherapy, you would die. I don't think I'll have any patients if that was really true, because most of my patients, in fact, almost all of them, do require chemotherapy, most of the time to downstage it, which is to shrink it. So you could have somebody who comes with a big 10 cm breast lump that they have just pinched a little bit from it, tested it, and it has told us that this is the type of treatment that it requires. We will give the chemotherapy based on that subtype, and you would see it shrink and even completely disappear. Now, when it completely disappears, the surgeon will still go back and cut around that region where it was, and we will send it back to the lab, and the lab will say, oh, there's a very small 1 cm tumor that's left, or sometimes there's even no cancerous cells seen again. With this, you have increased your chances of survival, because we know that when we have that thing that you don't find any, we call it pathologic complete response, it gives you a better chance of survival. So there is hope. The fact that you've been diagnosed with breast cancer, it doesn't mean this is the end of the road. It just means come out, do something about it, and continue living your life. And then you will go into the survivorship mode, which is the mode we want everybody to be. Like, we need more people to be more open and more, tell people their stories. Anytime I see any of my old patients, I tell them, why are you not coming to give health talks? Talk to people, come out and tell people. But there's this stigma that's associated with breast cancer, or any type of cancer for that matter, even amongst we, the healthcare professionals. I've had people who are healthcare professionals who say, come out and talk to people, so that, just to give them hope, to take away that fear. If they're seeing you and you say, oh, I'm a 20-year breast cancer survivor, and they're like, 20 years, oh, she's even my doctor. So that tells you that she's living her life normally. All she's doing now is just, follow-up care, making sure everything is okay. And, that's what you basically need to do at that time. So chemotherapy is not so bad. There are a lot of side effects, but if you are in the right hands, if you're with a clinical oncologist in Nigeria who is administering this chemotherapy to you, the side effects will be minimal. Another type of systemic treatment is what we call hormonal therapy. So among, like part of the breast, the specialized testing that we do, the tumor will tell you, I will respond to hormonal therapy, or it will tell you, I won't respond to hormonal therapy. So you don't bother giving tamoxifen to somebody who will not benefit from it. But if it tells you this, then you're better able to manage these patients, to help them achieve a cure, which is what we are all looking for. Another way is what we call targeted therapy, but all of this is just for you to know that even if it is found, that treatment options are available now that you can have access to be able to achieve that cure. And then the last thing on the list is the use of radiation. The kind of radiation we're talking about here now is the type of ionizing radiation, which is the ones that comes from gamma rays, X-rays. These are high energy radiations that we use to destroy the cancer cells. So then again, people will say, no, I heard that radiotherapy is like putting you inside fire, they would roast you and all of that. The area where it's being treated, I think the myth comes from the darkening that comes on the skin around the area that's being treated. So, but that darkening will fade away in like 4 to 6 weeks afterwards. So it's not like, and you don't even feel it, because I tell people, if you go for an X-ray or a CT, you don't feel anything. So it's the same thing, it's the same radiation that we're using. We will just irradiate that region. So you don't feel anything per se to say, oh, as the beam is coming, you're feeling some hotness or anything. No. In fact, some patients, when they finish, they're like, doctor, am I done? You mean that's the radiotherapy? Because they've heard so many terrible things about it. So treatment-wise, those are the options that are there for radiotherapy. You have 2 centers in Lagos that you can have radiotherapy, and the NSIA Youth Cancer Center, and there's a private center, Nassau Root, but clinics, I'm sure they are on the pipeline, because radiotherapy is actually hot right now. Everybody's going into, getting it, because we actually need a whole lot of radiotherapy machines in Nigeria. When you finish your treatment, survivorship is another part of it, because people need to know how to cope with this diagnosis, to say, oh, I've just been diagnosed with breast cancer, I've finished my treatment, what next? Things like the way to cope with your body image, the way to build up your self-esteem. There are some people who go into depression just because of this diagnosis. You need to know it is not the end of the road. Sometimes you just take it as a bump in the road, and you will just go through that bump and go back into your smooth life without, praying for any other bumps to come, which we will call, recurrences. So to sum this up, with most of the things that she has said about the prevention, the first thing you need to do is to know your normal. What is your normal breast? What does it feel like? So that when there's any abnormality in the breast, you know you need to do something about it. You also need to know your risk. Family risk of breast cancer. In Nigeria, we still have this notion of trying to hide, we don't tell, but it's important for you to tell your family, most especially that I've just been diagnosed with this, because it would help that person to identify such symptoms early. I've had a family with 3-4 sisters with breast cancer. So it goes to tell you that, yes, I know only 10 or 15% are actually genetic, but if those 10 or 15 who know that they have a family history are actually screening to come early, then we have actually done something. And then the general population, because they come, but nobody in my family, my generation, I've asked my mother's family, my father's family, and nobody has it. There's always a first person, but don't keep it to yourself. Share it with your family members so that they know that now we have a family history and we need to know, okay, pay more attention and examine ourselves. The other thing you need to do are the preventive measures that Dr. Oluwaseun has mentioned. Do what you need to do. keep fit, lose weight, be active. The couch potato, you need to be moving. So tell yourself at every time, even if you're working in a bank job, you could tell yourself like every hour or every 2 hours, I would get up and walk around the office, say hello to who I need to say hello to, and walk around and come back. Can I take the stairs instead of doing the elevator if it's just 3-4 flights? Can I just use it as my 30 minutes activity for the day? Because it's advised that you should do 30 minutes of active exercise every day for at least 5 times a week. So if you're able to use those office minutes as opportunities for you to move around and get yourself really active. And then the last of all, if there's any screening procedure, if there's any preventive procedure, please submit yourselves for this. So with this, I will end my talk on breast cancer and take it back to Dr. Oluwaseun to talk to us about cervical cancer briefly. Thank you.
Thank you so much, Dr. Emmanuella. Dr. Oluwaseun, please go ahead. It's so enlightening. And I also like the fact that we're making it as light as possible, and we're being very real with the conversations. A key takeaway from your talk around breast cancer is it's not a one-way treatment. It's not they're putting you in the oven. So it could be hormonal, it could be radiology, it could be chemotherapy, but it depends on what the problem is. So I know when we are done with this, I'm sure we'll still come back to all the myths, and you will help us move us from the microwave giving cancer myth to the real challenge is around real radiation, like serious radiation, CT scans, and what you might call it, X-rays and the rest.
X-rays,
so yeah. I don't know, Dr. Shen, are you up for one question? Because I can see somebody's hand up before we delve into cervical cancer. So
yes, we can take a question.
All right. Please unmute yourself, and we would like to take a question. Aditomo McGregor. Hello. Okay, I can't see the hand up anymore, but there's actually a question in the chat bot that says, how can we differentiate between a swollen breast that is dangerous and the one that is normal? Because I discovered that it's not all breasts that are tender.
Thank you. I think I have an idea of what the question is. So the best way to differentiate whether the swelling is normal or abnormal, if you are not sure, if you're not, if you don't know how your body system had been before that time, or you're not sure what to do, is to investigate further. If you notice significant change in the size of the breast, go for a breast ultrasound if you are less than 40. If you are 40, go for a mammogram. That is the subjective way. I mean, that is the objective way, devoid of bias, to know what is going on.
Okay. Thank you very much. Thank you very much, Dr. Oluwaseun. So, can we delve into cervical cancer for a tad bit? Then we'll come back to wrap it up with the myths, the question and answer, and we'll call it a day. Thank you.
All right. Please, just before we go into cervical cancer, I want to recount a real life experience that occurred that actually buttresses what Dr. Emmanuella said a few minutes ago, that most doctors, in some cases, may not even know that the person has cancer till it's, or even patient till it's advanced and they just present with back pain. You know that we are in the era of COVID. Thank God it's going down now. So a few months ago, in the heat of COVID, earlier in the year, a client was brought to clinics with difficulty in breathing. That was just what she presented with, difficulty in breathing. So we were skeptical to take the patient. We're asking for a COVID test. So the referring doctor told me that no, he has done COVID. But the doctor came with the client that he has done COVID test for her, and it's not COVID, but this woman is she's just breathless. She's on oxygen and all. And to now make matters worse, she just kept covering herself, covering her, She was just like really, really well covered, and she doesn't want to expose herself unnecessarily. Do you know that the doctor that brought the client, it was when she did a CT chest. It was from this chest that the radiologist was saying, this is meds everywhere. What happened? So that was when the client did not even, the patient didn't tell the referring doctor that she has had breast cancer in the past and had mastectomy. So when she came to the facility, it started again, and there were meds everywhere. She came in an advanced stage, and the only thing she presented was not even a visible breast lump. It was just difficulty in breathing. So it's just important for everybody to check as soon as possible. Once you notice anything is wrong, you go in, you get a second opinion immediately. Now let's talk a little about cervical cancer, because both cervical cancer and breast cancer account for their cancers. And the cervix is actually located at the mouth of the womb. So it's easier to check and notice if there's a lump than it is to know that something is going on in the cervix. And that's the place of regular screenings. That is the way of having your pap smear. We'll still talk more about pap smear. So cervical cancer is just uncontrolled growth of the cells of the cervix. It starts from the outwards, then it goes inside. There are like 4 stages, similar to breast cancer. The earliest stage, the cancer is still there, but by the time it gets to stage 4, there's already metastasis everywhere. And it's sad that most clients come in at that advanced stage. So what is the cause of cervical cancer? Like for breast cancer, there's no known cause, but there are so many risk factors. The first risk factor is having multiple sexual partners. Having so many people, multiple sexual partners, is a risk factor to having cervical cancer. Another risk factor is human papilloma virus. For like 80% of adults in reproductive age, they've had HPV, that's the human papilloma virus infection at one time or the other. But there's this serotype, there are different types of it. There's this particular type, that's the subtype 16 and 18, that if someone could predispose to having cervical cancer later in life. But do you know what the good news is? There is vaccine available to prevent cervical cancer. And for those of us with children, females of reproductive, in fact, before they even had their first sexual exposure, that is when the vaccine is most effective in preventing against HPV infection. So another risk factor is family history of whether breast cancer, cervical cancer, ovarian cancer. Family history of cancer is also a risk factor. Radiations could also predispose to having cervical cancer later in life. Poor immune system, weakened immune system can also predispose to it. By the time the immune system is loaded with HIV and then subdued with diabetes as well, and once the immune system is weakened, it could predispose to that as well. So then the signs and the symptoms, if we would go to that, cervical cancer shows symptoms till it's advanced. I had a brief posting in radiology team, in radiotherapy team when I was doing my house job, and it left an experience with me that I could never ever forget. Cervical cancer doesn't show early. By the time the person is beginning to suspect, it's already going into the advanced stage. So early ones, no symptoms, but by the time it's getting advanced, the woman begins to have bleeding, abnormal bleeding. That's in 3 folds. The bleeding could be one after menopause. A woman in her late 50s that has already attained menopause can suddenly start bleeding all of a sudden. It could be postcoital bleeding. That is after having intercourse with the husband. The woman could start bleeding. It could also be intramenstrual bleeding. That means before your next cycle is meant to start, the woman bleeds in between. please just note that it's not in all cases of these instances of bleeding that there's actually cancer going on. In cases like fibroid, for some people with fibroid, there could be bleeding inter-period. So it's just very important for us to investigate further once a woman notices any of those things. Another symptoms could be foul, very, very offensive vaginal smell. It's usually very, very offensive. It smells a lot. I'm sure Dr. Emmanuel will be able to talk about that. Offensive vaginal odor, vaginal discharge could be a symptom. Suprapubic pain, pelvic pain, pain in the lower tummy, recurrent pain could also it could also be a symptom of cervical cancer. And like Dr. Nwachukwu said, once it's advanced, it goes, the cervix, the womb is very close to the bone of the pelvis. So metastasis to the pelvis and the rectum, or the lower part of the intestines, they are common findings in cases of cervical cancer. So what do you do? How do you prevent cervical cancer? How do you even check for it? There are several methods people use. But so many church screenings, let me put it that way. I've attended so many church screenings, we do all this glacial acetic acid. In clinics, you don't even advocate for that. You go for your pap smear. That is one of the ways to screen regularly. Your pap smear. Once a woman is in reproductive age, for cervical cancer, you don't wait till you're 40. Once a woman is sexually active, once in 3 years, you do the pap smear, and you also do the HPV DNA. There are tests that you can do to check whether the person has human papilloma virus or not that could cause it. So you do the HPV DNA, you do the cervical test once in 3 years. If anything abnormal is seen, they could ask for further studies. They could ask for colposcopy. It does take time, a biopsy of the cervix to know what is really going on there. So basically, those are just the things to know, but you need to know how to protect yourself. So chastity, fidelity, sticking to one partner is not only beneficial for religious purpose, also beneficial for the health. So that's one of the ways to prevent cervical cancer. Also, avoiding smoking, avoiding excess alcohol, living healthy eating, healthy lifestyle, avoiding radiations. Those are things that you can do. And then getting the vaccine. I mentioned the vaccine earlier on. But if, for those of us on this presentation, on the panel, on the audience, if you've not gotten the vaccine, it's still not too late. Do the test, do your pap smear, do your HPV, go for the vaccine. So basically, those are just the things, but it's important to check for it. Pap smear is such that if you don't check for it, you won't know it is there. And I think maybe I just give room to Dr. Emmanuella to say about the things that were missed.
But a quick question before Dr. Emmanuel takes the floor, and it's directed to both of you, either or. Please, this HPV vaccine, how do you know if you've taken it in the past? Because I'm just thinking, have I taken this thing? Is this some? I don't know.
Okay. No. This HPV is intentional, such that when we were younger, like looking at you now, when we were younger in the 80s, in the early 90s, it wasn't very popular. It's not the kind of vaccine that we take for children. It's not the normal vaccine you give for babies when you are taking them to the hospital for vaccination. So it is in the last 1 decade that it became more popular. So most likely, if you are taking it, maybe somebody would have told you about it and you went for it. Or you could speak with your gynae, you could speak with your family physician if it was part of the vaccines you took. Most likely it's quite intentional because it wasn't common, it wasn't very popular before. So if you're taking it, most likely you would remember. If you are not sure, you could go for the HPV. This HPV, IgG, IgM. We do that in clinics also. HPV, IgG, IgM, you could see whether you've had an acute infection or a current infection. Basically, that's just what that would check. Then if you are not immune, if they're not having infection currently, you could just go for the vaccine. Hope I answered you.
You're muted, Omolara. Hello, Omolara, we can't hear you. You're muted.
Yes, I apologize. I said, I know that the pap smear bit, we have that covered, but I just wanted to know, and is there any adverse effect if you already had been vaccinated before and probably you didn't know and you get vaccinated again?
I don't think so.
So like Dr. Oluwaseun said, I don't think it's something that you can do and not know. Because
And not
first
know
of
about?
all, it's 2
That
to
means
3
I'm not
doses. Okay, it's 2 to 3
Mhm.
doses. 6 months, some of them you take the first one, 2 months later you take the second dose, 4 months later you take the third dose.
Oh,
So it's
same.
something that it is absolutely
Mm.
impossible for you to have done it and not know that you have done it. The second thing about the vaccine is it's recent. It's in the last, and if you want to check, like in other climes, they start to give children when they're from 11 years of age. So it's those people that would say, okay, maybe I took it at 11 and then I can't really, recall, but you have a vaccination card. On that card, they would write and sign the dates that was given to you. So you can always refer to, that immunization card to say, what vaccine have I taken? So, but the thing about vaccination is it's for boys and girls between the ages of 11 and above, and try to capture it up till 26 years of age. So the reason behind that was looking at it that it would be before you would have any exposure to the HPV virus. So because like Dr. Oluwaseun said, almost 78% of people would have had one strain of HPV through their lifetimes. So, but it's sexually transmitted. We want a situation whereby you can give the vaccine before the child even, has any sexual exposure at all. Vaccine is also, evolving. So initially when it started off, it was a 2 bivalent vaccine, which was just the 16 and 18, which are the high risk strains. But as more research is going on, they're finding out that it's not just the 16 and 18. Okay, there are some of them that cause non-cancerous genital warts, the 6 and 11. So they did another one to cover all 4. And then more research, they're finding out there are people who have cervical cancer who didn't have any of these strains. So like in Nigeria, in fact, because like 2 weeks ago, we were doing the International Cancer Week, and we were talking about, getting this HPV on the vaccination schedule in Nigeria. So if you know that as part of the way you take your child for your BCG, your hepatitis, and all of
so
that.
it becomes statutory.
It becomes statutory. So, but a pathologist raised something very important there, that there was someone who did research to see what type of HPV did Nigerian patients in that south state, what type of HPV did they have? And they found that it was not the common high-risk strains that were common among these people. So do we go and put this into our vaccination schedule? And we find out that it's not one of the ones that is being covered. But there's one of them now that is also available, which is a non-valent, which covers 9 different strains of HPV. So, there's a lot of work going on and saying, okay, anyone we catch that is a high risk, we include a vaccine that would cover that one, so that with this we'll be able to cover all possible types. Because majority of the patients with HPV, in fact, there's a terminology now that cervical cancer is a sexually transmitted disease.
I was going to ask that when we're looking at myths.
It is, because it is something that comes through HPV, and HPV comes through sexual intercourse. So you now tend to look at it. Yes, we talked about multiple sexual partners, but I also talk to women and tell them that it's not just you. It's not you.
Also your partner.
It's your partner. So we call it married to a high-risk partner. Okay, so we say people who have multiple sexual partners. It's quite funny. People who have multiple sexual partners and who are married high-risk partners. Okay, so in the days back in medical school, then we used to say, oh, if somebody was married to a trailer driver, it was a high risk because he would drive through many states and have multiple women going down the lane. Or if he was an army officer, oh, that was another high risk. But now you still have men who are high risk partners or doing their normal day work. So, but it's always something we have to preach out there. It gives the woman, it's easy for the woman to receive the HPV and have cervical cancer. But the thing the man must know, one, there are also male diseases, okay, that can come from HPV.
Mm-hmm.
I've seen patients with penile cancers. I've seen patients with anal cancer. Okay, all of these are all HPV related. And then most commonly now, they're finding a lot of people with what we call oropharyngeal cancers that are caused by the HPV. So this is because our sexual orientation is also changing around the world. So people are doing a whole lot of stuff. And you're now finding that you're from oral sex, you're able to give your oropharynx at the back of your throat a risk for developing cancer. So this is the reason why the boys are also involved in the vaccination program. So when you're doing the vaccine, you're doing it for both your male and female children who are 11 years of age, so that it also reduces their chances of having oropharyngeal or anal or any of the other, cancers
Orifices
that can come from these orifices.
Mm.
So, besides that, then apart from the other risk factors that she talked is about having multiple children. I don't like to talk about breast and cervical in the same meeting, because what is on one end for breast is on the other end for cervix when it comes to this having children. If you don't have children, if you have few children, is a risk factor for having breast cancer. However, when you have 5 and above, it is a risk factor for cervical cancer. So when you do studies, you find that majority of the patients with cervical cancers are patients who have more than 5 children. The cervix keep opening, closing, birthing, closing, all that trauma. And sometimes I have seen a patient who comes and say, I have 18 children. I'm like, I give it to you. You're just like, there's nothing else. As in, so when my resident is presenting to me and says para 18 and para 14, I'm like, okay, so cervical cancer down the line. Yes, this is where we are. So it's something that we need, cervical cancer, for something that is so preventable. It's something that we need to pay more attention. Like she said, it's not where we can touch, it's somewhere inside. And that's the beauty, where if you're doing HPV vaccination to reduce this and you're doing your smears, you will find out like that in the next 5 to 10 years, the possibility of me having cervical cancer is there. So what can I do? What can I do to, eliminate this? So let's talk about the staging. Now, if it's a very early stage, which is the stage 0, this is what we call pre-invasive. We have CIN1, CIN2, CIN3. These are the ways that it would usually chart its course. If you haven't finished having your children, there are surgical procedures. Let's even start from laser therapy. There's cryotherapy, where they freeze the cancerous cells at the tip. But this is because you're seeing it just on the surface layer of the cervix. It hasn't gone into the cervix proper to invade it. So you can freeze, what we call cryotherapy. You can cut off just that region. We have what we call cornization. You can scrape, what we call leap. All these things are ways for early treatment. So this is where we're moving to say, we're preaching for people to do screenings to find it. Now, when you find it in that 0 stage, you need to make these treatments available, because it's unfair to find it and not have the treatment available to give those stages. Now, if it now comes to the stage 1, if you say, okay, the patient has also finished having her children, she can opt to do a hysterectomy to remove everything, so that she knows that the chances are slimmer of it, recurring, but you still require follow-up. Same thing. Majority of my patients will come in stage 3, stage 4. It is something that it is difficult for me to harness. It's difficult for me to manage these patients better. They come to you when in fact, their PCVs, because of how long they've bled, are 12%, 15%. The kidneys are shutting down. This is not the way it should be, because this is one that just changing your location being in the US or in the UK, your chances of having that same cervical cancer has dropped drastically because you'll be called, you'll be reminded, you'll be written, in fact, I'm sure they will even come to your doorstep to find out if you're still there and still alive. You need to go in for your smears. Same thing for the vaccination. They would come, they will call you for your children. We need to get this, information. We need to get data on we don't even have good population statistics. So it's why most times I laugh when I hear all these things, because most of the people who have cancers, they are in the villages. We haven't even identified them to even count them among our statistics. So this is the reason why we must take the word out there. The people who do need these vaccines, people who are in the villages, some people for religious purposes, for tribal, there's no information out there to tell you that you need to have this vaccine given to you. So, and that same person, because her mother had 12 or 14 children, she would probably, and another very important thing is cervical cancer, young coitus, the age at coitus, which is the age you are when you have sexual intercourse. So by the time you're looking at childhood marriages, it will also be, it's a ripple effect. It's a ripple effect. You will go in, have obstructed labor. This child is not old enough to even have a child. She will have obstructed labor, give trauma to the cervix. At the end of the day, the cervix will complain about all of this. So treatment-wise, what we have is surgery for early stages, chemotherapy and radiotherapy for more advanced stages. Same thing, we give it, but because you never can tell who's going to respond. On Monday in the clinic, I had a patient who, when she presented to me about 8 months ago, in the peak of COVID, she needed to be having dialysis 3 times a week because cervical cancer, there's something very typical. When your ureters that carry urine, where they enter into the bladder is just close to the cervix. So when the disease is advanced, it blocks the urine from coming back and it destroys your kidneys. So when they come, because of the mass that is there, she's not able to pass urine. The kidneys have shut down. She needed to be going on for treatment on and on 3 times. I told her daughter, well, what can we do? Let's start treatment. And when she came in on Monday, I'm like, when last did you do dialysis? She's like 3 months ago, I've stopped doing dialysis. My kidneys are back up. Everything is okay. And I'm like, wow, you see, in this, you never really give up. We still, we still offer the care we need to give because you never know who would, respond and bounce back. And she said so many things. Doctor, I can't thank you enough. To me, I thought it was over, as in, I don't know, my daughter was just like, no, mommy, let's try. I'm like, this girl doesn't know that this is the time. But surprisingly, she's the one who was treated. She's the one who has now done very, very well. She's responded well to the treatment, and now she's on follow-up and she's doing really well. So it's still about presentation. I wouldn't have loved her to come at that stage. I prefer she comes in at stage 1 where I would just do brachytherapy or something for her to make things better. But if you still come in at that stage, it's better to still present. Another stigma, about it is most of the time you have it in older women who have stopped seeing their periods, and they find it really difficult to share with their children that something is going on. So they start seeing the bleeding and they're wondering, but I thought I had stopped. Some of them will say, okay, maybe it's the menses that's coming back again. So it's for me, I feel it's...
That's post-menopause, I suppose.
Yes, postmenopausal.
Oh, so postmenopausal
bleeding. So you find these elderly women, they find it difficult for them to share with their children, to say, my child, I started seeing this. So, but even for the younger woman, you meet with your spouse, you see bleeding, please come up, do your pap smear. It doesn't mean it's something. It could be some hormonal change, but it's better to speak up and catch it at the earlier stage. Another important thing is the presence of HIV, like you mentioned. Immunosuppression does predispose you to developing cervical cancer. Now, I would say that the earliest stage of cervical cancer patients I have seen are my patients with HIV. Why? Because they are the ones who they preach the word to in their STC clinic. They preach to them, they come there, they do their smears, and then They just catch it at the end when it's just changing into cancerous cells. Those are the only patients. Every other one, because if you're waiting for symptoms to come, when symptoms come, the foul smell, Dr. Oluwaseun, that I'm sure it's the smell has touched her life. That's the reason why she knows she will never forget it.
I can never forget it. It was really.
It is difficult to forget. As I'm here, just talking about it, I can smell the whiff. It is something that you don't even wish it on your enemy.
Absolutely.
Because you can't walk past someone without everybody turning around like, what is this? Offensive. That's the word. It's really, really foul smelling. So please, when just listen, like we said, over and over, listen to your body. The discharge comes, it's brownish, it's tinged with blood, it's reddish, and it's not your period, okay? You watch out to see, does this happen again? See your gynecologist. Do your smear. Find out what exactly is going on. The smears once in 3 years. We don't need HPV testing. It's fantastic that clinics has it. Please go there and do co-testing. It gives you peace of mind for another 3 to 5 years that cervical cancer is out of your thoughts, your thinking. But it's something that we just have to. The youngest patient I've ever seen was about 16 years of age.
Wow.
Cervical cancer. It's we always have the oldest. Okay. So it's something that we need to really pay attention to. So thank you once again.
Thank you, Dr. Emmanuella, for this. We have a lot of questions, but I think we should quickly take Olayinka Bodi Folashade. She has her hand up. So, or he, I don't know if it's a he or she because the name is unisex, but Olayinka, you can just unmute yourself and you can ask a question. Or is it a historical hand or an error? I'm not sure. Okay. But whilst she's trying to do that, we have some questions here. Where are these vaccines available, please? So where can they get people are asking where they can, how they can access the HPV vaccine and where?
Okay, so on my own end, it's still not hospital-based vaccines. Most of the people that are vaccinated are because the pharmaceutical companies who make all of this are usually working with us, so we're able to do that. But I'm sure if you go to any of the private institutions, okay, they would be able to get the vaccine for you and tell you how you're going to take it based on the type that they have available. So please reach out to your HMO. The thing is, most people don't ask, so that's why they don't get. But it's not in the government. You can't walk in to say, even if you walk in for the government, you need to procure it to bring it because it's not yet on our immunization schedule. So, but I know that a lot of work is being done, and we're hoping that by 2022, we'll have it on the immunization schedule and to be readily available and cheaper, because right now it is expensive. So those are part of the drawbacks to our getting vaccination for everybody.
Okay, thank you so much, Doctor. Yeah, Dr. Sean, go ahead, please.
Yes, I wanted to say that for Lagos, for instance, I know that you can get the vaccine in Lutz. You can actually walk into the GOPD, the health patient, and get the vaccine. In Lutz, you could get it in Lasut. I know Victory Drugs, quite a number of big pharmaceuticals actually import it. So if you go to like Med Plus and all those big pharmaceuticals, they will tell you, yes, where to.
Okay, fantastic. At least now we know how to get the vaccine. Then and there's another question here that says, people under the age of 30s and 40s that have not had sex before, are they likely to have cervical cancer? You see, one of the myths, they started coming out.
So for that one, we have this myth who would say that a reverend sister has no business having cervical cancer, but she has a need to have breast cancer. You see why I said I don't like both of them, because where her not having children predisposes her to having breast cancer, her not having children and then not having had sexual intercourse that is supposed would protect her from having cervical cancer. So, but because of the small percentage that is not related to HPV, okay, there's a small percentage of cervical cancer that is not related to HPV. Because of that small percentage, it is still possible for somebody who has not had sexual intercourse. Now, there's one drug, diacetylstilbestrol, DES. So in the 30s to like 1971, most women who used to have recurrent miscarriages and all of that, they were given this drug to help them to keep their babies. But by 1971, when they found out that that drug could actually cause harm to the mother and give the mother a risk of developing breast cancer, and to the baby in her womb, the risk of developing a type of cervical cancer that is an adenocarcinoma, a clear cell adenocarcinoma. These are the things that they looked at to say. So we have them called DES mother, DES daughter, and DES son. So the mother who took the drug, yes, she exposes herself to having the possibility of having breast cancer. And then the DES daughter, who was in the womb when she took it, has the risk of having, cervical cancer. So all those people, there are things that you need to, just for information's sake, because if you were born after 1971, then the chances that your mother took DES is
very minimal.
Yes, it's really, really slim. But the thing is, in Nigeria, we still don't have protocols. It may still be one old gynecologist somewhere in 1974 that will say, madam, you've had too many miscarriages. I think it's important for you to take this medication. Not knowing that it had been stopped, based on that.
Okay. There's another, thank you very much, Dr. Ella. So another question here says, are there known effects of taking the HPV vaccine?
Okay, so yes, there's been a lot of myths, everything with vaccines. This COVID vaccine, it was same thing for HPV. Okay, people said they took it, they got paralyzed, they took it, they became mute, they took it. The truth is, with vaccination, it goes even further down to childhood vaccination. There are vaccines MMR vaccine, a lot of people didn't give their children because they felt, it caused autism for them. And there are these things about vaccine, but I believe it's individualized. There are people who would take the vaccine and would have, real serious side effects. So it's not like it's not documented that there are side effects that occurred as a result of exposure to the vaccine. But majority of people, because they would have checked the safety profile before they bring out the vaccine. So majority of people will not have any reaction. That's the reason why it's still.
Okay.
Sorry.
Yeah, go ahead.
One last thing. Okay. So if the side effect that's being asked is something like fever or something like chills, those are common side effects, not just to HPV vaccine, but even to other vaccines like the COVID vaccines and all. That's why you give children paracetamol after they are through, they run fever. So few side effects like that can occur. But like Dr. Ella said, to a very large extent, it's actually safe.
Okay. Thank you very much, Dr. Sheon. There's another question here. Somebody just put an opinion here. In my opinion, many of these were not common in some years back in Africa, although that might be a result of inadequate data capture. However, the recent surge is alarming. Why is this so? Could it be a result of modified lifestyle pattern? So I would answer, I'm not a doctor, but I would answer from an information management perspective. So people are now, in a couple of years back, we won't have this type of webinar. We won't have people that will come out and say, you know what, I'm raising up my hand, I'm a cancer survivor. People were known to keep it to ourselves. Nobody has to know, they will know I had cancer. Yeah, no, nobody must know. They cannot know. So we are known to shield that information, not even provide the opportunity for doctors to even learn more about the disease, or even sometimes some people will find out, then they'll just run away and never come back, and they will die with it. So I think from an information management perspective, I feel like a lot of vices, diseases, and even great things that are happening in the world today. Technology is helping us bring all of these things to the fore. But the other part of the question is what I would like for the doctors to speak to. Could this be a result of modified lifestyle pattern? And this brings us right into the myths because let me use my mom as an example. She'll tell you microwave, there is it can cause cancer. If I keep my food in plastic in the freezer, there will be some radiation that will enter my food, so I'm not going to do that. Some people say canned foods, GMO type food. So what is your take on all of this? The modified lifestyle pattern. I know sedentary lifestyle, we're now more sedentary. People are not going to the farms, walking 2-3 kilometers, properly exercised, obesity and all of that. But some of these myths, what are your thoughts around that? And how can we be very deliberate about being the best versions of ourselves per time?
Okay. If I could take the floor first before Dr. Hela comes in. According to the World Health Organization, WHO, initially, like 20-30 years back, the burden of sub-Saharan developing countries, the disease burden was more of infectious diseases than non-communicable diseases like cancers and all. But now, the burden of non-communicable diseases like cancer is now, because for those infectious diseases, you now have antibiotics and so many things to manage them. But for non-communicable disease, the incidence and prevalence is rising, even in developing countries, due to modernization, due to modified lifestyle, so many increased smoking, increased alcohol, and so many unhealthy foods, junks and all. Sedentary obesity is increasing even in developing countries unlike before, and so many things. Fine, we didn't have enough data before, but putting data aside, lifestyle diseases are now the commonest class of diseases worldwide, even much more than infectious disease, unlike how it used to be before. All right, so microwave does not cause cancer, but definitely it's unhealthy to eat food in plastics. I don't know if you understand that. Eating food in plastics may not be very advisable. Then the main thing, there's so many myths, there's so many things that people say, don't eat this, don't eat that, don't do this, don't do that. What is most important is eat healthy, eat your fruits, eat vegetables, be physically active, move around like 30 minutes every day. I use my phone to monitor my steps. I try to check for steps, because I do a lot of medical reports for companies and so many things. I look for an excuse to move around after some minutes, then I'll go back to my seat. Yesterday, 2 days ago, one of my health check clients told me that for 8 years, he works on the 8th floor in a stockbroker firm, stock exchange, and he does not take stairs. In 8 years, he has not taken the stairs. He has just taken the elevator, sorry. He just uses the stairs. That works fine for him. The person will have healthy weight when I saw him. So that works fine for him. You need to know yourself. You need to listen to your body, and you need to just make healthy choices. If you say you don't want to have cancer, you don't want to have this, and you're smoking, and you're taking alcohol, and you're having multiple partners, or those are things that are not healthy. More importantly than microwave, whether you eat your food or not, those are things that carry weight. Exactly. So those are things that we should give attention to. All right, thank you. I think I would allow Dr. Hela at this point.
Yes, so I think another thing that is responsible for the increased number of cases is the awareness that is coming up. A lot of people are not a lot more aware. There were times that people would die in the villages. The woman, in fact, okay, I remember that among my colleagues at a certain time, we said, oh, the woman in the Bible with the issue of blood had cervical cancer. Okay, so it goes as far back, but there were women who died after bleeding profusely in the village, and nobody took a record to know the reason why she was bleeding. There are places that a woman will have abdominal distension, okay, in Nigeria, abdominal distension, and they'll tell you that it means you've had extramarital affairs. And you know, they would be there telling the woman, you better confess. You better confess. If not, this thing is going to kill you. These are things that were not recorded. So all those women died without a diagnosis. But now, because of the increased awareness, the children of that woman will not listen to hear that their mother will be kept at home, forcing her that she needs to confess for infidelity that she didn't do. Meanwhile, it might be related to that. So it's because of the information that sometimes it's not with the mothers, it's more with the children. There are a lot of jingles. People are coming out there saying, check your breast. And then one day you see mama's breast with something. You bring her into the hospital for her to come and seek further care. So these are the reasons why it's looking like, oh yes, there are a whole lot of cases now. It's because people are a lot more aware and are now beginning to seek, you know, for help. That notwithstanding, behavioral changes and lifestyle changes that are occurring here, we are modernizing our lifestyle. So breast cancer used to have, of course, it's still higher in white women than blacks, but when it does occur in blacks, it is more aggressive and deadlier. So they have more, but we that still have lower than them, our own type is not like that. But when it comes to cancer care, there are some types of cancers that they find that if you move from one destination to another, you pick up the incidents like the place where you are living. It gets to tell you that there is some environmental, there's some lifestyle adaptation takes place that, you know, that comes from, you know, these things, either by maybe what you eat in the place where you settle. I know for colon, that they will say people don't eat, we eat spaghetti, indomie, things that don't form a lot of bulk. So you can go 4 days and not empty your bowel because your bowel has not had enough. But in the olden days, you will eat fufu, you will eat swallow that in how many hours you are in the bathroom and you've cleared your intestine. So it's all those things that we need to look at. It's the reason why we need to research a lot more for us to be able to say categorically that yes, it is on the increase and this is what is most likely responsible for it. For the microwave gives what we call non-ionizing radiation. Okay, so the microwave, your phone, your radio waves, they are all non-ionizing. They are not big enough to be able to damage the DNA the way the ionizing radiation, which is the X-ray, the CT, and the normal ones that we are talking about. So, but if we don't, no matter what, we just tell people, because it's difficult to be able to explain fully until you do further research. So, but just tell them that it's best. Microwave is not going to cause cancer. I have patients who live in the village that don't have microwave and they come down with cancer. So I don't think it's only, if not, I would have seen it being skewed and only the urban dwellers would have been having cancers. Which other myths did you mention? I think that's all. Yes.
Okay, so I'm just also what I'm laughing is I know we're all on this table. All of us that have received those forwarded messages from our moms that will say, do not put your phone beside your breast. Do not put your phone something, radiation from your phone, something. I know we get these messages, but at least we are getting first-hand information from a clinical oncologist saying to us that microwave will not give you a cancer, so it can be used. Thank you very much, Dr. Ella, for that. Somebody put a question here. A person said, can a breast cancer patient take the vaccine, the HPV vaccine?
Okay, so two of them are not related. So it's good enough for you to take, depending on your age, depending on if you've screened to make sure you don't have the HPV already and you don't have any of the high risk types, because the thing is, the vaccine is against the HPV, it's not treatment for cervical cancer. Okay. So you need to know to make sure that it's not that you already have the HPV strains 16 and 18 that are the high risk strains already present in your body, and you're hoping that the vaccine will do it. Because I've had patients come in and say, but I took the vaccine. So the thing is, if you already had the HPV, then the vaccine is to prevent you from having it. So,
but you already have what it's trying to
already have
prevent
what
you
it's
from.
trying to prevent.
Okay, thank you. Somebody else also put here, sorry, let me just get the person's name. The first question, the other question was from Jennifer Abiola. This one is from Christiana, and she says, there are so many vaccines now. Are there known interactions of the HPV vaccine with others? For instance, can one take the HPV vaccine along with the HBV vaccine? Is there HBV vaccine?
Yes, that's hepatitis.
Yes, hepatitis B.
Oh, hepatitis B. So can one take?
The thing is, I don't know about taking it at the same time, but they have different schedules. Okay, the vaccines are not things that everything falls about the same time. Even within the HPV, which is the human papilloma virus vaccine, it depends on the type. If it's the Cervarix, the Gardasil, or the Gardasil 9, they all have different schedules. So it's not possible, it's not likely that they will fall in the same scheduling time. So, but hepatitis B is something that a lot of us would have had our vaccines in childhood. And if you didn't have it in childhood, please, it's advisable for you to get fully vaccinated against that as well. So please, there are two very important vaccines. Just put them along your immunization schedules and have them done.
Okay. Thank you so much, Dr. Ella, for that response. Somebody, I already put here, very important. Yes, there's a need to be on the, yes, when you were speaking about the HPV vaccine, I guess, there's a need for it to be on the routine vaccination schedule. Educating the public is important. Education of cervical, the cervical smear, so that being the pap smear most likely is important. But there's something else I'd want to touch on this education thing. Now, because of the way you have spoken about the HPV vaccine, I think it's something that we have to be more deliberate, even we as alpha and also women, to take it out there to schools. Because, you had said that the time when women or the best time to take it is just before a girl becomes sexually active. Yes. And at that age would be most likely between, say, anything from 11, 12 and up to about maybe 16, 17. So we know, if we have to be real, we know the realities of what's going on out there. So I think that we all have to be more deliberate, even in our small groups, church groups, mosque groups, religion. Let's just be more deliberate, talk to younger girls and probably their moms about the HPV vaccine, the availability, because prevention, like if I can prevent this type of, if one can prevent this type of problem, there's no point to not taking it. You get, because I'm just thinking, like, if I were 13, okay, I'm 13 years old. If I were 13, I'll be so happy to, please, you know what I mean? I'll just be so happy to make myself available to. So let me just run through the last few comments, then we're wrapping up already. Christina also says, these treatments we are talking about, how cheap are they? Are they available? Can the government step in for public funding? So,
for which of the treatments now?
So a patient has been diagnosed with breast cancer or cervical cancer. So now there is a challenge. The person there's a problem. So how expensive is it on, like, from an average perspective? Like, is it very, very pricey to treat? Is it something that we as women have to start considering, okay, maybe later years, so that we put things like life insurances in place that can cover healthcare at that time?
So it's very important for us to actually do have insurance coverage, because cancer care, so let me use breast cancer as an example. For breast cancer, you can have, like I said, because of the subtype, There's a subtype of breast cancer called the HER2 positive breast cancer that you can use 7 or 8 million naira to treat it. It's that expensive. But there's another subtype of breast cancer that you can use maybe under 1 or 2 million naira. I'm talking of for the chemotherapy. Radiotherapy is also another expensive adventure for us at National Hospital. I think it costs 600,000 naira for radiotherapy. But in Lagos, it's about 1.2 million. So all of this is not cheap. And with all the research that's coming up, we're having newer drugs for targeting these cancer cells and, based on the type and everything. These new drugs, when they come out, they cost an arm and a leg. So it's difficult for the average Nigerian to be able to afford it. The National Health Insurance Scheme tries to cover some of this treatment. So if you can't afford to be on the NHIS, we advocate for you to do that. The second thing is the federal government now, I think in 2018 or 2019, they started off at the Catastrophic Health Fund, which is now called the Cancer Health Fund, which is for helping indigent Nigerians. So we are still in the kickoff process. We're about to start, and we've enrolled some patients on it. And I think it's supposed to be a maximum of 2 million naira that will be given to each patient. That's the maximum that they can give you. But I'm saying if you now happen to have the type of breast cancer that requires 7, 8, 10, 15 million to treat, of course, 2 million is a drop in the ocean for you. So it's something that if we have, better private insurance coverage like they do elsewhere, why they are not flinching. I've had patients who have been on one drug that's each one costs about 1 million naira, and they've been on it for 4 years. So there's no way if you're in Nigeria, you'll be able to afford it. But the reason why they are on it and still being alive, despite having stage 4 that has spread, it's because they are in countries where insurance is working for them. So.
Thank you. Thank you so much.
One additional thing. Yes, one additional thing. The figures that Dr. Hela quoted, that from national hospitals and thereabouts, even in private hospitals in Lagos, it is much more expensive.
It's a whole lot much more expensive.
Yes,
that's why you can even see the difference in the radiotherapy, where we are charging 600,000. You'd get like 900 and something thousand in Luth, and get 1.2 million naira in Masobro. So it's just private centers. So it's something that we need to really look into cancer care in Nigeria.
So that for me is even the heavier blow. So ladies, if you don't have a health insurance plan, that I think it's high time to start talking to possible insurance companies that can support you. I know that Union Bank has a bank insurance desk that will do well to sit with you and also refer you to the right path per insurance and how to protect yourself against these possible types of eventualities. But somebody also has put here that there's a charity in Ibadan that supports that helps cancer patients called LEAH, L-E-A-H. So it might be something people can check out and see how they can also get support. I know that there are a lot of the Cancer Society in Nigeria. There are a lot of support groups there that also help encourage women, one another, and also corporate organizations actually do support cancer patients to get proper healing. The whole idea is not to pay lip service to just, we're doing breast cancer awareness for what it's worth, but how can people actually get value? How can it be real that, this thing is a prevalent problem? And as Dr. Oluwaseun said earlier on, before it was 1 in, I think it was 10 in 10,000. It used to
be 11 in 100,000.
11 in 100,000.
6 in 100,000.
And it's 56
and that
now
is still not the real figure because it's grossly underreported.
Exactly. And if we're not very deliberate about it, right, We don't know when it will become 500 in 10,000, and God forbid. No, but that's just the reality. We just have to be very deliberate about putting these pillars in place. Somebody also said, I think it's important to have a routine screening invitation for your cervical smear. It needs to be government driven, yes. But the reality is, I'm a realist. You know the society you live in. The government is not going to do that for you right now. Maybe they have plans to do it further down the line. So, like the way you see how children are vaccinated today, that wasn't what it was before. At some point, it was parents actually submitting their children for vaccinations and doing it by themselves and tracking the vaccinations. But now it has become mandatory. So I think it's very critical that we are responsible for your life. So just be responsible for that part as well. Now that I know about the vaccine, personally, I will read a bit more about it and I'll present myself to take it, just to protect myself, to make sure that nothing or no semblance of cervical issues come up later on. Somebody also put here, and I'm saying somebody because I'm not sure if the person would like for us to state it. We actually have a cancer survivor here, and I'm really appreciative of you coming out to state this to us, that you are on 5-year post-treatment cancer of the breast. Early detection helped me. And the reason why I'm reading this particular one out is for all of us here, this is somebody that has gone through the trauma of this, but she came out to say early detection helped me. So please get yourself checked. Check yourself. If you feel funny, if you think there's anything there, just go into clinics. I know that through the month of October into this November, I'll just have to reconfirm with clinics. There's a promotion going on for breast cancer and cervical cancer for about 3,500 naira and 6,000 naira. Yes, it's still on. So for you to get tested, that's all you have to pay to know exactly what's going on with you. So as she said here, early detection helped me. So it's critical for us to all get ourselves checked up. Honor says, my question is for Dr. Seun. Hello, ma'am. You're saying when you have an offensive smell, does it mean that does it mean you have cervical cancer, and what are the treatments for that, ma?
Okay, so having offensive smell does not mean a woman has cervical cancer. Sometimes, it's like a sexually transmitted disease called chlamydia. The vaginal discharge is fishy smell. It's foul, but it's fishy smell. But it is not due to a cancer. It's actually due to to another organism, not cancer. So what you just need to do, if you notice a vaginal odor that is quite unpleasant, investigate further. You could start your investigation. You could do a pap smear. You could do if you're having discharge also, go ahead and do a high vaginal swab. Swab it, do your VDRL, check for syphilis, check for sexually transmitted diseases, and do your pap smear. It goes together. It is not in all cases of foul smelling or offensive vaginal discharge that there's cancer. But it's just that, that one you see in cervical cancer. Dr. Ella also emphasized for me, I've experienced it because I've attended to cancer patients during our job. It's just really, really bad. It's gross. It's bad. You can hardly stay close to the person without wearing a face mask. And back then, face mask was not even, it just became very popular now. So it's not in all cases that it's into cancer.
Okay. So thank you so much, Dr. Oluwaseun. So what this really means is that once you even say, ladies, it's as I've said earlier on, it is your body. You will know the smell of what is going on down there. You will know what is normal. You will know how you are during your monthlies. You will know what happens just immediately after. I know that people talk about douching and not douching. I don't, because I feel like um, I've spoken to so many medical doctors to the point where I know that it's not, you need the healthy bacteria to down there.
Yes.
But at the same time, the same way people will say some people have body odor. But you will know what your body smells like. You will know what you smell like. Now, if there is something completely off, if there's something off that you cannot place, right? You can go to the hospital to go and check. It doesn't necessarily have to be a cervical cancer. It just might be a sexually transmitted infection. It might be a toilet infection. I don't know. Was that very common one that people just we can extend. Yes, it might be that. It might be anything. But just present yourself to the doctor and get the best help. So that brings me to my next question, and we're going to round up in 10. Could STIs become? Are they like pathways to becoming or rather untreated STIs? Are they pathways to becoming cervical cancer?
Okay, in some cases, if it is frequent, untreated, it could be a risk factor. It is not in all cases that it would lead to cancer, but it's a possible risk factor. But not in all cases, it's just a possibility.
The thing about it is the chances of you having HPV along with the STI is very high. So if you're getting an STI from a partner, it means this is a promiscuous partner who would probably also be giving you the HPV along with other sexually transmitted infections. So when we're asking history, we usually would ask to say if you have other previous STIs, then we know that this is somebody who has the likelihood of having had HPV among one of those.
Okay, thank you very much for that. So somebody has Adeton has put the website to Leah Foundation in Ilorin as well. So for people that want to get that need support through probably cancer journey, or they want to know exactly what's going on, I know that there is also some free services provided by the Lagos State government. So they always run the free cervical and breast cancer service, and one has to just fill a form. We'll put it also up on the Alpha Woman website so that you can also see and check that you can get all the required information that to get tested. But also to mention, Ecolab, one of our other partners, also provides the services to women. And Ecolab, they as a clinic, has branches in Lagos and Oka. Ecolab has branches in Abuja. They have branches in Benin. They have branches in Lagos. They have branches in I mentioned Abuja, I think Kaduna. They have branches in about 6 places, 6 locations nationwide. But what we'll also do is we'll put all these locations on the Alpha Woman website so that you can check and see where it's closest to you, so you can get yourself checked out. And thank you very much there is one last, this is the last question. What's the main difference between vaginitis and cervical cancer?
They are very different. Vaginitis, they are not even close. Vaginitis is an inflammation, most likely due to an infection. But cervical cancer is absolutely different. It's a cancer. It's an abnormal growth of cells. So they are totally different. Vaginitis is an inflammation. Though if you go for your pap smear, they could tell you, oh, no cancer cells seen. Well, there were inflammatory cells seen. So when you get that kind of comment, that means that you go for a vaginal swab or an vaginal swab or an endocervical swab to just check for infection. So they're absolutely different. There's no abnormal growth of cells in vaginitis.
Okay. All right. Well, the other thing I wanted to just touch on, last. So if somebody now finds out that, okay, the person has cervical cancer, early detection, is taking out the whole uterus, like if it's someone that has, you're already done with childbirth and all of that, or you're like, you know what, I am open to other options like surrogacy and adoption, just is taking out the whole uterus an option that will take away all the cancer cells?
Yes, it is. But most importantly, it's very important for you to stage the patient first.
Okay.
If you do not stage, if it is a stage 2B, surgery is not advised. It's better for you to go for radiation and chemotherapy afterwards. But if you go in and you do surgery at that time, then you would have sort of like worsened the case for the patient. So it's better for you to stage properly. And if you stage and it is truly a stage 1, and the patient is sure that, you know, I'm done with my children and everything, I'm ready to have it taken out, then yes, it is advisable. It is one of the treatment modalities. Let me just say advisable. It's one of the treatment modalities because that's you can offer this patient. And I just want to say, I don't know, the Leah Foundation, I think is one of the, so we have this FLAC, First Ladies Against Cancer. So I think Leah Foundation is one of the First Ladies Against Cancer programs. So they have a coalition of First Ladies in Nigeria who have come together to help raise awareness for cancer patients, their treatment and everything. So
fantastic. Okay, so I'll just like to say thank you, a big, huge, mighty, fantastic thank you to Dr. Oluwaseun Akindasa and Dr. Emmanuella Nwachukwu. This has been a very engaging 2-hour session. Somebody had put on the comment box that this is the first time she's actually sitting through a webinar for 2 hours and she's not bored and she's not logged out. So I'm sure that you have done a fantastic job about talking about the myths, talking about how to test yourself, what to do when you find out, and how to get help. And just understanding that you are not alone in the journey. You have your whole medical team and you also have your family and friends to lean on. So there isn't any point keeping to yourself, getting into depression and creating another set of mental health possible issues as well. So I'll say thank you very much. We really appreciate you. We will put this webinar session up on the Alpha Woman website, and we'll also do well to send a copy as well to you so you can also share with your own communities. As I said to everyone on the call, Alpha is Union Bank's proposition for women to enable and support, to enable and empower women regardless of your segment, wherever you are. We are here to support you, your healthcare, your savings needs, your lending needs, whatever it is that you need. Alpha Woman, Alpha is a safe place. It's not just financial services we are selling. We're not even selling it. We're telling you that this is where you can come to and get all the advisory you require to get you from one point to another point in your life. So thank you very much for spending 2 hours of your time today with us. We really appreciate you. And that's it from me, Lara Abiola, Head Alpha. Thank you.
Thank you very much for the invitation. Thank you, Lara and the rest of the Alpha crew. Thank you. It's been an insightful and enjoyable webinar.
Yes.
Thank you.
Thank you very much to Lara and the Alpha Women team. It has been a very good session, very educative and interactive. That's more like the word. So those are the things that we actually enjoy when you hear feedback. People are asking questions. So to end it, I would say once again, please listen to your body, know your risk factors. Okay, get screened. And if it has any prevention, please do something. Go for your annual mammo if you haven't done it, please. go for your 3 yearly cervical smears if you haven't done it. Okay, so anything that we can prevent, please, and then healthy lifestyle changes. Okay, thank you very much. I really
share the message. Share the message to your friends as well.
Share the messages, exactly.
Yes. Ask your friends. Have you ever had a mammo? Have you ever had a pap smear done?
So you could invite me to a birthday party and the women sitting down and I'm like, okay, so it's time to preach. Let's go. How many of you have had your mammals? This is how we need to get the word out, because you might just speak to that one person who hasn't heard about it. So please spread the word out. Thank you.
Yeah, thank you so much and enjoy the rest of your day. Bye-bye now.
All right, thank you.
All right, thank you. Bye-bye.
Bye.